thank you for a kind invitation to present our program. And I will present an example of developing patient-centered solutions for people with long-term conditions. And as part of that, we are using self-care platforms, and I will come back to that after some elaboration on the program itself. And I have to warn you, because we're still struggling with terminology. We're using self-care and self-management, and harmonization of terminology across primary care is one of our activities in order to support communication and implementation. And where are we now? Well, you're well aware of the rise of chronic disease that's all across Europe, and it's a general epidemiological and demographical trend. 1/3 of our population is suffering from a long-term condition. And there are three familiar ones with 1 million diabetes patients, and we're targeting at the diabetes patients and the other ones as well, but we started with diabetes. And we have been working over the last decade with multidisciplinary pathways, and they were very successful if you look at the outcomes. But at the same time, we see that the strict protocols that are used by the nurse practitioners and the assistants do not suit everyone. It's targeted at the average patient, and there's still little room for improvement following this approach. And that's the reason we thought that we could do something else, because if you look at the number of dots representing the hours awake, hours you are awake in a year, you see that the patient, even with some attention, I see it's wrong, 12 hours you see your physician, your nurse practitioner, and other healthcare delivery personnel, and the rest of the year they're out on your own. And how can we support the patients in their need to self-manage? We decided to join forces, patient associations, care providers, and health insurance companies. And each of us have their own reasons to be involved. For the healthcare providers, it's the question how to organize and provide sufficient and appropriate care, and do that in a sustainable way. The patient organizations feel that their needs and ambitions will not be met using the current policies, and the health insurance companies get very nervous if they look at the trends, and how can it be paid, and how can sufficient and appropriate care be organized. So, what do we do with our collaborative? We designed a collaborative with 3 equal parties from the patient organizations, the health insurance companies, and the healthcare providers, especially the GPs. And we defined a plan to accommodate the supported self-care, as we call it. In Dutch it's called zelfzorg ondersteund, zo. What we want to establish is another way of interacting between the GP and the patient. Another attitude of the GP supported by eHealth tools, and also accommodating patients with their own needs and ambitions, and not only doing it right in a project phase or a program phase, but aiming at sustainability and look at implementation at the beginning, and using existing tools and energy from existing parties involved. And one of the nice things that come from us from across the channel is the comprehensive approach in the concept of the house of care. And we use it very often because it's such an elegant model, and it's quite simple, and it stresses the interdependencies that are involved with successful implementation. And we all have graveyards full of well-meant projects aiming at just one of the parts of the house of care, aiming at the professional part, improving guidelines, or aiming at IT solutions, or just getting the financing right. And we found out, as many others, that it only can work if you aim at all the parts of the house of care at the same moment. And being it so elegantly, we can always refer to it. And as one of the crucial factors, there is the attitude change aimed at the GPs and supported by the patients using their eHealth applications. And what we're willing to do is illustrated by the story of Corrie, a video.
Ik was een oud wijf. Echt. Niks kon, niks wilde, niks dik deed, niks doen. En toen bleek dus dat ik suikerziekte had. Het begon met 1 pilletje en even later werden er 2 pilletjes. En een paar maanden later werden er 3 pilletjes. Dan ga je dus naar de praktijkondersteuner, huisartsen. En toen kreeg ik aangeboden een 3-maandelijks lifestyle-programma. Daar werd Kees mijn fysiotherapeut.
Corrie was een uitdaging. En ik probeerde nou in mogelijkheden te denken en kansen. En eind 2013 heb ik haar toen uitgedaagd om deel te nemen aan de Diabetes Challenge die we toen aan het organiseren waren. En dat heeft voor haar eigenlijk de definitieve omslag betekend.
En daar heeft hij me eigenlijk een beetje ingepraat, want lopen, dat was helemaal niks voor mij. En toen ben ik aan het wandelen gegaan. De eerste keer 10 minuten en de tweede keer 15 minuten. En het wouwde zo heel erg langzaam om. En toen kwam door dat lopen, door het wandelen, toen was het de ommekeer, zeg maar. Het werd allengs een beetje vrolijker en gezelliger. Ook voor mijn omgeving, denk ik. Denk ik wel, ja. Toen ik met lopen ben begonnen, mocht na een half jaar ongeveer, mocht het eerste pilletje eraf. En vorige week, 2 weken terug, hadden ze gezegd van nou, stop er maar met die pillen, want het gaat helemaal goed, je bent stabiel. Ik wilde het wel van de hele wereld schreeuwen, zeg maar. Dan ben je zo waanzinnig trots. Dat is zo ontzettend leuk. Ik denk dat ik weer mijn oude zelf ben, mijn jongere zelf. Ik ben mijn jongere zelf weer, dat is het dan.
Well, Corrie is a real-life case, but as we know that all patients are different, and in our program we want to accommodate the differences between the patients, and we often use the metaphor of the pilot, the co-pilot, the stewardess, or the passengers, and we're used to service passengers. And there still will be passengers, but we also want to accommodate the other ones, varying from the pilots to the stewardesses. And in accommodating them, we can fulfill their ambitions and activate them. And so tailor-made solutions are necessary. And we want to address the issues around information, education, monitoring, communication, and with all different types of pilots and passengers, you are confronted with different points of attention. And that's not a problem if you can support them with suitable eHealth solutions, if you can engage the local and personal networks, and first and foremost, if care providers will adopt another attitude. And in doing so, we are faced with some challenges in implementation. And we see scientific evidence, but we also want to use the evidence from practice. How do you consult? Which skills do you need? And what questions have to be solved to get your return on investment right? And what we saw was that there were some proven eHealth tools available, but we had to work on that as well. Very important are pre-competitive rules for health insurance companies to set rules for contracting and commissioning without competing for patients whom have long-term conditions. And what we see is that after a few years we've developed implementation guidelines. We've involved half of the care groups that organize long-term condition care, and we're aiming at 25% of the diabetes patients next year to have some form or another of self-management or self-care. And we want to create an environment where self-care is normal, which is quite a challenge, but after 3 years, I'm rather amazed it still flies. It's one of the tables where the atmosphere is very constructive. There are, despite all troubles between the health insurance companies and the healthcare providers, really willing parties involved and trying to get the best out of it, which is inspiring. And the self-care portals are a prerequisite for supporting patient and professional interaction. And what we did was that we defined specs for the portal to set a framework, and we have the experience with the GP information systems. We've got a framework of specs, and there are around 10 parties that offer the information systems for GPs. And the defining of the specs was very important because it shook up the market, and there are now 5 parties certified, and they will be compensated for the cost involved. GP groups that adopt the self-care systems will get compensation, so there is no need to pay them from their normal budget. And we're still working on the connections that are crucial. How can we get the information from the self-care portal to the professional information system and to the patient's personal health record? And the spec definition and the audits proved to be very powerful drivers for change, but we face enormous problems with the two-factor authentication. We are required by law to use a two-factor authentication, and we see a lot of dropouts of the patients, so we still have to solve that. Amazing is that the clear set of specs delivered various approaches that are really very different in approach, starting with the patient or starting with the information system from the GP. And what we can see is that if you center on the patient while developing such a portal, it will be adopted more easily, because the extended version of the GP information system will not meet the intrinsic needs of the patients. And we're still figuring out how to promote use, because in a way it's a chicken or egg dilemma. We've got the systems in place, but it's not really being used very much. So that's a question we've got to solve the coming years. At the same time, the shake up of the market inspired a national initiative to provide patient access to health records. And we want to combine these efforts to be more influential and be successful.